directly blood flow from the arterial circulation into the draining vein, bypassing the capillary beds. They are less frequent than aneurysms, with a prevalence at about 0.15% in the general population. An AVM has three components. There is a core of these plastic vessels, the nidus, dilated arterial feeders, and dilated draining vein. There is no normal neuronal tissue within the nidus. The most frequent presentation is the hemorrhage, and about half of the cases, seizures and headaches play a secondary role. The first thing we need to know is that the risk of bleeding, AVM bleeding, is greater than the risk of aneurysm bleeding. They have an annual risk of rupture at about 3%, and there are also independent risk factors for rupture, like associated aneurysms, previous rupture, the small size AVM, and the deep venous drainage. The goal is to determine the risk of conservative treatment versus the risk of intervention. In 2013, the results of the largely criticized Aruba trial were published with the conclusion that medical management alone is superior to the interventional therapy in patients with unruptured brain AVMs. The results of the final follow-up were published in 2020 with the same outcome as the original trial. So, should we still be treating unruptured brain AVMs? In some cases, yes. That's an example of an untreated unruptured AVM, first diagnosed 5 years ago in a routine MRI. The patient refused the treatment at that point. She came 2 weeks ago, 2022, with the right side hemiparesis due to a newly formed venous varix compressing the motor cortex. The most common classification, AVM classification, is the Spätzler-Martin classification. It takes into consideration the size of the nidus, the eloquence of the adjacent brain tissue, and the pattern of venous drainage. It predicts the morbidity and mortality risk of surgery only. It does not necessarily apply for endovascular therapy. How do we diagnose an AVM? There are non-invasive techniques like CT, MRI, functional MRI, diffusion tensor imaging, but the main diagnostic tool is the angiography. It's an angiography. It's capable of characterizing the whole AVM architecture, the feeding arteries, the draining veins, the presence or absence of risk lesions like aneurysms. Please bear in mind that an angiogram following hemorrhage can be false negative secondary to nidus compression. So the gold standard is a follow-up angiogram 3 months after the original hemorrhage for AVM detection. Here is an example of an angiography showing an intraneedle fistula. It's practically impossible to see on a standard MRI or CTA. The goal of treatment of an AVM, it's practically the complete interruption of the arteriovenous shunt. It's the only aspect that eliminates the risk of hemorrhage. Partial treatment makes sense, for example, in treating weak spots in the AVM angioarchitecture, like associated aneurysms. The mode of treatment, there is primary microsurgery, primary radiosurgery, but the part we're going to talk about in the next minutes, it's the primary endovascular treatment, or endovascular treatment as a precursor for operative resection or radiosurgery. So we're going to take care of these 2 points here because that's the most important part. Embolization for definitive cure, it's doable, but in a minority of cases. A few technical aspects. We use in most of the cases a flow-guided microcatheter, like Magic 1.2 from Balt. We also use wire steerable microcatheters like Marathon in combination with Mirage guide wire. If we use Onyx, we're going to go for Apollo or Sonic microcatheter with detachable tip. As embolic agents, we predominantly use liquid embolic agents, and in the majority of the cases, we go for gluburan. Why? Because it's of its rapid polymerization and the ease of controlling the speed of polymerization by adding lipiodol. We don't use on a daily basis Onyx, Quid, or Fill. I know some of you are using them as a standard embolic agent. The main advantage of Onyx, for example, it's the longer injection time, and you can allow a certain degree of reflux around the tip of the microcatheter without being afraid of sticking the microcatheter in the vessel. Coils, we practically don't use it alone. We use it using in combination with gluburan, with NBCA. We use them to slow down the flow through the AVM to be able to use the liquid embolic agent in a controlled manner afterwards. Curative embolization, well, the obliteration rates are pretty low. You can expect like 30% for NBCA and 24% for Onyx. It's gonna work in small AVM with a single feeding vessel and a compact nidus. That's an example of such AVM with a pretty compact nidus here, one draining vein, and one single feeder, this one. It was occluded with 1.2 milliliter Onyx, and follow-up angiogram showed no arteriovenous shunt anymore. In most of the cases, we tend to embolize an AVM before operation, before resection. The main goal here is to convert a high Spetzler Martin AVM to lower grade lesion. It reduces the morbidity and mortality of the surgery. It also reduces the blood loss and improves operative time. That's an example here. You can see a pretty large AVM post-central. The next images here show about 80% reduction of the nidus without occluding the whole AVM. And after embolization and surgery, there is no arteriovenous shunt anymore. Also, preoperative makes sense to take care of the risk lesions, aneurysm, as in this case. So the proximal aneurysm was coiled, and the distal aneurysms were occluded together with a parent vessel. We can see here the blue cast occluding the aneurysm and part of the nidus. And the postoperative image shows a complete obliteration of the AVM. Embolization prior to radiosurgery. Well, the main goal here is to decrease the size, especially the volume of the AVM, so that allows higher dose of radiation to a smaller volume. It also makes sense to take care of these risk lesions because it reduces the hemorrhage risk in the latency period after radiosurgery. And here one example, you can see here the nidus with these 3 draining veins. Here is an image with an injection of glubran. And on the next slide, you can see an angiogram after embolization with a significant reduction of AVM size. Here are the planning imaging for radiosurgery and a follow-up MRI. 6 months after radiosurgery, it's like almost half of the AVM is obliterated. 24 months later, there is no AVM residual on the same spot. And 3 years later, the angiogram shows here a complete obliteration of the AVM. Palliative embolization makes sense for very large, non-resectable AVMs. Like in this case here, you can see this monstrous AVM. On the right side, this patient was having daily seizures, uncontrollable, and after 4 embolization sessions with glubran and coils, we reduced the volume of the initial AVM without being able to occlude it completely. The seizures were not that frequent anymore, so we reached our target in this case. Complications. Well, there are hemorrhagic and ischemic complications. The hemorrhage complication can be a result of arterial perforation, occlusion of the draining vein with venous congestion and bleeding, and also the so-called normal perfusion pressure breakthrough. That would be the loss of autoregulation in surrounding ischemic tissue following embolization. That's an example of normal perfusion pressure breakthrough. You can see here pretty large AVM prior to the last embolization session. And on this angiogram after embolizing 2 of the arterial feeders, you can see here contrast media extravasation. Here, it's pretty rapid. So we went and closed the feeders leading to this bleeding. And a few minutes later, started to bleed from 2 other regions, and multifocal bleeding. So the patient was rushed to the operating room and had the AVM resected with this pretty big defect on the right side and poor clinical outcome. Occlusion of the draining vein can also end in catastrophe. So this is a case of pretty large AVM, which was planned for a final preoperative embolization. The idea was to close as much of these arterial feeders as possible and then occlude the vein. That's an angiogram after embolization. You can see here the vein was partially occluded, but we didn't reach the desired occlusion of the arterial feeders. That resulted in a high pressure on the draining vein, which led to this massive bleeding. One more aspect, it's the high rate of recurrence of AVM in children. That's a case of a 8-year-old girl presenting with headaches. You can see here an intraventricular bleeding. The MRI showed suspected as a small AVM on the left cerebral hemisphere, which was later confirmed by the angiogram. You can see here the AVM. It's better to see on the lateral view. So the AVM was embolized and resected with a very good technical outcome and clinical outcome. You can see here there is no arteriovenous shunt anymore. That was July 2018. 3 years later, routine follow-up. You can see here again the presence of a pretty high flow shunt. So we went again for embolization and resection, again with a very good clinical outcome. That's the image after embolization and resection. Okay, so the next slide, we're going to talk about tips and tricks, and especially about adenosine-induced asystole. We use that in high-flow AVMs. What it does, it slows the blood flow through the AVM for a controlled deposition of the embolic material. We inject 36 milligrams of adenosine through a venous catheter placed in the right atrium, and that gives us about 20 seconds of induced asystole. That's here an example. You can see the tip of the venous catheter in the right atrium, and also the defibrillator. This is the AVM to treat. It's a pretty compact AVM, but with a high flow. On the next angiogram, you can see the position of the microcatheter and also the high flow of contrast media through the AVM directly into the vein, the draining vein. And here under cardiac arrest, the very slow controlled deposition of NBCA, reaching only the proximal part of the nidus and the main feeding artery. The angiogram shows complete occlusion of the AVM. So, the summary, only 10 to 25% of intracranial AVMs are likely to be cured with embolization alone. That's why the multimodal therapy is the key. Larger randomized trials and prospective registries are needed to establish the place of standalone or neoadjuvant endovascular treatment. And the main challenge remains the risk assessment of conservative treatment versus interventional surgical or radiosurgical treatment of unruptured AVMs. Thank you very much.